Alright, for the first lecture on our heart, we're going to look at cardiac muscle tissue and electrophysiology of the heart. So luckily, we don't have to consciously control our heart rate. Otherwise, we'd have to be going beat, 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 beat. That would get very annoying. So our cardiac muscle has autorhythmicity. So it can beat without the input from the nervous system. It's self-excitatory. It still operates on action potential, so we're still going to have the inflow of ions to depolarize the cells, and we're going to have the outflow of ions to repolarize the cells. But with heart, because we don't need the stimulation from the nervous system, we have a unique population of cells that are self-excitatory called our pacemaker cells. And these pacemaker cells start the contraction, and they rhythmically and spontaneously generate that action potential that spreads to the other cells of the heart, and 99% of our cells are going to be these contractile cells. So here is the makeup of our cardiac muscle cells. This is a photomicrograph, if you recall back in A&P1 with their histology. So they're going to be fibers, similar to what we saw with the skeletal muscle, and they're striated. But they are different in the fact that they are branched and that they have these intercartilated discs in them. And so same makeup, sarcomere, I-band, A-band, myofibril, sliding filament model, all that's the same. Our T-tubules, where the action potential invaginates down into the center of our muscle cells, stimulating an all or one contraction. And these gap junctions that we have within the incartilated disc are also make it able for the heart to contract as an all or none. And so it rapidly sends those ions from one cell to the next so that the action potential can travel all the way across the heart. And that way the heart can contract as a single unit. Because the heart does contract with such force, we have these desmosomes. And here's an artist's depiction of this. And so here are those desmosomes. And they help to hold each heart cell to the next, allowing the heart not to rip apart as it contracts, because the heart can contract pretty forcibly, especially when we get excited or start exercising and some of those types of activities. And here's a little bit more visual depiction of our gap junctions and how the ions travel from one heart cell to the other to our adjacent muscle cells so that that action potential can travel rapidly throughout the heart. And so again, our same action potential, but we have an additional channel here called a calcium channel. And so our calcium channel and then a non-specific cation channel is available also. And so you can see with this slow initial depolarization, we're having these leaky channels. And so here you can see around minus 55, thresholds at minus 40. Remember, threshold is where an action potential actually is fired. And so here we have a non-specific cation channel open, causing a slow depolarization. And then when we reach threshold, our calcium channels open, and we have a rapid influx of calcium. And so these are our pacemaker cells. Remember, we have two types of cells. We have the pacemaker cells and we have the contractile cells. And so this is the action potential of our pacemaker cells. And so as that calcium enters, we have that rapid depolarization. And then when we hit up around plus 10 millivolts, we have closing of those calcium gates and opening of our potassium gates. Again, very similar to what we would call back with our skeletal muscle action potential. And when the potassium starts to flow out of the cell, we see repolarization. And then our repolarization does the hyperpolarization and then comes back up. And you'll see in a slide coming up that the time interval is much greater in our pacemaker cells and in our contractile cells than what we used to see in our skeletal muscle cells. And we'll look at a comparison of that in just a few minutes. And so this cycle continues to repeat. Average heart rate is between 70 and 75 beats per minute. All right, so these are our pacemakers. We have some nodes. So we have the SA node. This is where it all starts. This is what generates our initial action potential. Then once we generate that initial action potential, we spread across both atria, and the atria contract. So depolarization is followed by systole. Now remember that we need to refer to heart contraction as systole, and heart relaxation is diastole. And so the action potential spreads across both atria, stimulating them to both contract simultaneously. That action potential is delayed for just a few seconds in the AV node. So we have a delay of that action potential in the AV node. So with this AV node, we slow down our action potentials to about 40 per minute. And so that gives time for the atria to finish emptying. And then we move down into the AV bundle. Again, we have a set of pacemaker cells here, and they actually only depolarize about 20 times per minute. So we're slowing things down as we move through the heart to give adequate time for the ventricles to fill and the atria to empty. Once we hit the AV bundle, then we split into the bundle branches. And so now we're going into the left and right bundle branches along the left sides of the interventricular septum. We get down to the apex of the heart, and once we get to the apex of the heart, the action potential spreads from our bundle branches along the Purkinje fibers on the outer walls of both ventricles. And then the ventricles enter systole. Following behind up here, we are having repolarization of the atria, so they are going into diastole as the ventricles are going into systole. And so that is the makeup of our conducting system of the heart and how it causes our heart to beat, alternating between diastole and systole. All right, let's watch a quick animation of how the conducting system of the heart works.
As you observed in the experiment, contractile cells do the work of the heart by contracting, but they need pacemaker cells to tell them when to do it. The pacemaker cells function like an officer giving orders to soldiers, telling them to move. Let's now look at how those orders are communicated. During a normal heartbeat, action potentials originate in the pacemaker cells of the SA node. The impulse spreads across the atria, both via the internodal pathway and through gap junctions between contractile cells. At the AV node, where cells are small and have few gap junctions, conduction of the impulse is slowed as atrial contraction proceeds. The electrical impulse leaves the AV node via the AV bundle and rapidly propagates through the bundle branches. Rapid conduction continues throughout the Purkinje fibers, depolarizing the ventricles. Ventricular contraction follows depolarization. The contraction ends as the ventricles repolarize and relax.
Okay, so with each population of pacemaker cells, you can potentially pace the heart. But remember that they beat at different rates. So the SA node up here beat at around 60 beats per minute. AV node only beats at about 40 beats per minute. And then down here, the AV bundle at the beginning of our bundle branches is only going to beat at about 20 beats per minute. So 40 would be enough to sustain life, but 20 would only sustain life for a very short period of time. And usually the fastest of our nodes sets the pace. So that is always going to be the SA node, but if something did happen to the SA node, the AV node could take over. It just slow the heart rate. And you can occasionally have a group of regular contractile cells or pacemaker cells that will attempt to pace the heart at the same time as the SA node, and that will cause an ectopic pacemaker and cause irregular heartbeats. So we have the two populations of cells. Remember, with our pacemaker cells back here, we had 800 milliseconds. So pay attention to this time scale. The resting heart rate was between around minus 50. The threshold where the action potential came was at minus 40. Now when we look at our contractile cells, and remember the pacemaker cells have already started the depolarization. So we've already got channels open and ions flowing through those gap junctions into the adjacent cells. And so we get a rapid depolarization. Resting membrane here, minus 85, rapidly depolarizes to plus 20 due to the sodium channel gates being open. And so we have the activation gates open, then we have the inactivation gate closing or plugging that channel. And so now the flow of sodium stops, potassium gates open, the activation gates open, we start to have repolarization, but we have an additional step in these contractile cells to where we have calcium channels open, and they prolong the depolarization. And so we get this plateau phase as the depolarization is prolonged. And then that is going to be for about 100 milliseconds, I think, if I recall correctly. Or around 150 milliseconds. As you can see, the refractory period in these contractile cells is a lot longer. It's only like a millisecond in our skeletal muscles. But then we have more potassium channels open, so then we have a rapid repolarization back down to resting membrane potential. And here is skeletal muscle compared to our cardiac contractile cells. And so if our heart had an action potential similar to skeletal muscle, it would beat about 15 times faster. So it would beat at about 15 times faster than it does normally. And that plateau phase, as I mentioned earlier, slows that action potential down to about 200 to 300 milliseconds, giving time for the ventricles to fill with blood and allowing them to fully fill before the action potential travels through the ventricles, causing them to depolarize and then to contract systole and eject the blood out of the heart. So to look at the electrical signals through the heart, we use an ECG, an electrocardiogram. And so the P wave is going to show you atrial depolarization. And once something depolarizes, it is followed rapidly by contraction or systole. The QRS is going to show ventricle depolarization, masking the atrial repolarization. And remember, repolarization is when the heart relaxes or goes into diastole. And so repolarize, relax. Then the T wave shows ventricular repolarization. So depolarization, then followed by atrial contraction, ventricle depolarization, followed by ventricle contraction, and then ventricle repolarization, followed by ventricle relaxation. Remember, contraction is systole, relaxation is diastole. You can also look at other things on our ECG. R to R is a complete cardiac cycle, so a complete cardiac action potential. A P to R interval is the duration of atrial depolarization and the AV node delay. From the Q to T interval, this is the entire duration of ventricular action potential. And then that ST segment is the plateau phase, which allows the ventricles to completely fill before they contract. Here is it all put together with all the different intervals and segments in a ECG. You can diagnose issues with an ECG, so cardiac dysrhythmias, bradycardia, heart rate under 60 beats per minute. Tachycardia is a heartbeat over 100 beats per minute. And so this will tell you if your heart's beating too quick or too slow. You can also have disturbances in the conduction pathways. So a normal conduction pathway may be disrupted by accessory pathways between the atria and ventricles, or by a blockage along the conduction system, a heart block. Common AV node blocks, PR intervals longer, or extra P waves are present. And so this means that when the extra P waves means that all of the action potentials generated by the SA node are not being conducted through the AV node, so the atria will depolarize twice before the ventricles depolarize once. Another common location for heart blocks is that left and right bundle branch, and generally with that you would see a QRS complex widening. With fibrillation, you can have atrial or ventricular fibrillation. With atrial defibrillation, you just see a disruption in between each QRS where you can't see a distinguishable P or T wave. When you have a ventricular fibrillation, you just get a very unrhythmic signal on the ECG. And so you would hopefully defibrillate, shock the heart, and get it back into a rhythm, reset that SA node so it will fire regularly as it did before. And so you can also have something called flatlining. So flatlining is not the same as ventricular fibrillation. It is called asystole, no contraction. And so that would be fixed either with CPR, because with asystole there is no electrical activity, so there's nothing to reset. And so you'd have to physically pump the heart with CPR, or hopefully get it restarted with pharmacological agents such as atropine or epinephrine. Alright, so this ends our electrical conducting lecture, and there will be another lecture released on the mechanics of the cardiac cycle. Have a wonderful day.